move the microphone to midget height. Thank you. So I'm a bit of a wild card. You're going to make my IT work. Because I'm not an educational supervisor, so I'm not really an educationalist as you like. But I do lots of training of kind of different groups of people. I'll just wait for my slides. So I'm going to talk about a little bit of my experience with the military and kind of how I've moved that across to Civvy Street, as it were. So as Anton kindly said, in my day job, I'm an anaesthetist intensivist pre-hospital doctor. I spend about a third of my time doing all those things. But I'm also an Army reservist. I've been in the reserves about 10 years. So I've had the good fortune, perhaps, of doing a couple of tours in Afghanistan on the helicopters. And for anyone who's had anything to do with kind of reserve services, you might think, oh, well, it's just a colleague going off on a bit of a jolly. Okay, we're going to get some experience. But what good is that? It's just a little rota gaps for us to cover. And actually, I think I see it as a bit of a relay race. And certainly, I went out to Afghan when I was a trainee and did my higher module in military anaesthesia and things. But actually, I brought quite a lot of stuff back with me that I kind of put into the NHS. And I'll talk a little bit about how the Army trained me and how I then used that. But then that just flipped back in, because then some of the when it goes quiet in the military world, there's nothing particularly going on that I'm going to get sent on at the moment. Then we're relying on Civvy Street to kind of, and all the advances in technology and kind of ways of working, that when suddenly the military world does get busy again, we may well pass that baton back, and we may well have learnt some things from the civilian system. So, I mean, the Army is quite well respected for kind of taking people and breaking them down and building them back up again. And they're quite effective at that. And I have used quite a lot of the stuff that the military, I'd say, did to me in my training to kind of try and break my people and make them into something that I wanted them to be. Because I think there's lots of overlap with the kind of two worlds. And particularly, as Anton said, the intensity of what we're doing, we're going out to the biggest, sickest, most smashed up patients in the whole of Wales, just as we were in Afghanistan. We were flying out to the most sick and injured patients. And it's not enough to think that, I do a lot of training with my ICU nurses, for example, and they say, if something goes wrong, we'll just know what to do. But we all know when things go really wrong, you really do sink to the level of training, and you see people in a rush just going ABC, 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 and you do, so it's really making sure that the level that you're sinking down to is a good level, and that obviously with a high-performing team, the higher you can push that level, when the wheel really falls off the job and you are at that kind of the case of the year, that you perform well and do a good job for your patients. So I say the military taught me lots. I didn't get too many buckets of water in my face, but they do have a certain way of doing business. Not all about buckets of water in the face, but a lot about kind of their ethos as a group and how you identify with each other, and having a kind of strong ethos and certainly a kind of strong leadership identity. I think you automatically then, the team that you're working with automatically have some shared values, and that makes it easier to kind of train people in a way. It can be quite difficult to move this cross into Civvy Street, and certainly coming back into the NHS, it can be quite challenging sometimes, because in the military you can just get things done and make things happen because they have to. In the NHS, I'm sure there's a little bit more red tape to climb over and climb through. And certainly, so PDT is pre-deployment training. So once I did my basic training of them kind of beating me up and making me subservient and making me take command and follow command and then take command, when I kind of had, you're going off to Afghanistan, we went for a series of pre-deployment training. And it's quite stepwise. I did it for a whole year. I did it alongside my day job, which normally you don't. You normally be taken away for 3 months and do it. But I was a trainee, and I just wanted to get to the end. And you have quite specialised courses for your own specific individual role. You have some of it, so you do battlefield advanced life trauma support, and that might be just me getting good at putting tourniquets on, doing certain manual things. You then move into something where you're working with your whole department. So then I had a MERT course where me and the 3 other guys I'll be working with practice doing jobs together, practice the kit that we're going to be using. And then you move that into a kind of whole bigger role. So what the military have up in York is a big kind of empty hangar, and they set it up just like the hospital out in Afghanistan. When they went out to Sierra Leone, they tore that bit down and they put it all back up, so it was just like the hospital in Sierra Leone. So you could practice doing your day job in exactly the same environment. And as you can imagine, it's quite heavy on high fidelity simulation. They want to see that you can do your job, so the best way of seeing that is putting you in an environment where you have to do your job. This Hospex was what we did in the whole hospital in the hangar. Because ultimately they want to see if you're ready to deploy. If you're not good enough to do the job they want to send you to, they won't send you. So it is pretty much pass or fail. So they gave us quite realistic scenarios. These guys at the bottom are amputees in action, and they're very good actors, and they have fake bits of legs strapped on that look very, very realistic. And it helps you certainly as a person turning up to the course to buy into it, but I think it also stress inoculates you. So the first time I picked up a casualty in Afghanistan, okay, I wasn't used to the smell of the kind of the explosive devices, and you can't replicate the smell of blood and sweat and things like that, but I had seen something that looked a bit like a guy had both his legs blown off. So I think it was good to kind of stress inoculate you, and also it was good for my trainers to see how I worked under extreme pressure. This felt real. I didn't realise I was on the back of a fake helicopter. It felt real. And certainly moving through the hospital, you want to test systems and processes. You want to test that everybody there, particularly that command teams and leaders, can kind of do what they need to do when the going gets tough. And check, things like SOPs. We're in the military, we have lots of standard operating procedures because, people are drifting in and out at different times. We need everyone to be doing things in the same way. And so we're checking that people, they know them and they're using them appropriately. The guys, you probably can't quite see, the guys with berets on are the instructors. You can just see a lady there. So they're all the instructors that are watching us, ticking whether we're doing the right thing. And they would provide some constructive feedback if things weren't quite right. And it was a kind of training kind of week where they try and kind of build you up and get you better. But equally, if at the end, despite that, you weren't good enough, then you failed and you didn't go out to Afghanistan in the job you thought. And the job I was doing out of there was a reasonably high-intensity job. So MBE is a medical emergency response team. It's the helicopter that flies out to the front line, lands in the green zone, gets shot at a bit, puts the casualties on, and then we fly back to the hospital. And then while we're on the back of the helicopter, we put the guys off to sleep, we put tourniquets on them, we give them blood, we put IOs in them. So we do all that kind of ED-level stuff, but we do it on the back of the helicopter, flying tactically with body armour on, getting shot at. So a reasonably high-pressure environment. I always kind of say, there are parallels with the pre-hospital ward in Civvy Street in terms of some of the patient care we do, but on the whole, unless we're in a really rough area of the valleys, we generally don't get shot at. Our life is at risk. We're performing high-risk procedures in very, very sick patients in a very imperfect platform. It's very hot. I'm wearing body armour that weighs a quarter of my body weight. You're on a moving platform. So you can see how being a really, really well-drilled team and working with each other very, very efficiently and effectively to kind of minimise that, try and kind of stop all of that from affecting you is quite important. And as I've alluded to, we have lots of standard operating procedures. We are very, very familiar with our kit. I don't need to be like, what bag is such and such? And I need to know exactly where it is so I can put my hand on it. We have lots of checklists. We do lots of kind of drilling of, so we'd have literally, right, let's do our double amputation drill, and we'd load a fake casualty on, and we, in 5 minutes, everything was done. And we do lots and lots of simulated stuff because we needed to have lots of practice behaviour in our back pocket. So then if we did have a really sick casualty, well, we're kind of used to that. But actually, if it was that there was loads of gunfire out the back door and that was a bit distracting, we'd still be able to just click in and do our job. So I kind of bought, that was a really good experience, quite scary, but I kind of learned lots and lots, not just about medical stuff, but kind of about how to train people and how kind of I perform under pressure and how to kind of bring that out in other people. So that was 2013, I think Afghan pretty much closed up. And then in 2014, I kind of got approached. I was doing some pre-hospital stuff in Bristol because Wales didn't have doctors and their air ambulance. And we were looking to try and set it up in Wales because clearly we've got an air ambulance, but it just had paramedics on it, so it was really a flying ambulance. And what we wanted to do was put doctors and lots of kit and blood and all the good stuff that we'd had in the military onto the back of an helicopter so that we could kind of fly the hospital to the patient. So I got involved in helping set this up. And I think because of my experiences, and it was all quite busy, we did it all in kind of 6 months from flash to bang. I kind of led on kind of workforce and training. So EMRTS, at the moment now we have 28 consultants from a reasonably narrow variety of backgrounds, but from very different backgrounds in terms of trainings. You might think, you just stick an anaesthetist on a helicopter. If all they're doing is putting people to sleep, it doesn't really matter if they're doing it in a theatre or doing it on the side of a road, but it is a really, really different thing. So some of my consultants had lots of pre-hospital experience in well-governed systems. Some have got some pre-hospital experience in kind of basic schemes, which isn't quite as governed and didactic. And some have got very little experience. And it's just an interesting kind of thought that I had when I was looking back at what we did. And sometimes it is easier to take somebody who's almost a blank chalkboard and kind of build them from scratch than it is to try and take apart some of the bad habits that people have accumulated over time. Similarly with the practitioners that work with us, And a lot of my time now is spent training practitioners and my consultant colleagues. They're from a variety of backgrounds. We have nurses and we have paramedics. Some have already, again, different experiences. Some already work on air ambulances, some have worked in other systems, or some have never been on a helicopter, never done pre-hospital in their life. And certainly we've got a stream of really good emergency medicine nurses coming through us now. And it is really like fascinating seeing kind of how they develop. But the process we put them through, I think, helps them develop as quickly as they do. Just a quick slide on how we select them. Everyone says, oh, it's Amy doing her army stuff again. We do a physical test, so they, obviously you standard process of shortlisting. They do a physical test. If it's a physical job, you know, you think, oh, well, it's easy. You just land on the top of the hill. The valleys are a nightmare because you either have to land at the top or the bottom. And if you're far away from the patient, that's you and your 20 kilos of kit on your back and your ventilator and your blood bag, walking jogging a mile to the job. So you do have to be quite physically robust. So I can't have people who can't carry weight and walk briskly. So they do a mile kind of slight jog with a heavy backpack. And then we do a lot of kind of clinical and stress testing of them. We want to see how up to date and how sharp they are clinically. I need to see what their non-clinical skills are like. Can they get on with people? Can they kind of lead people well? Can they follow well? How do they perform under stress? And we do that all in a kind of timed environment. So they do 2 clinical scenarios, all kind of closely watched. And depending on what we're doing, certainly I've got consultant selection this weekend, and it won't just be clinical stuff. There'll be loads of non-clinical stuff. There'll be irate relatives. There'll be lots of pressure on them because I need to see them like really, really under pressure and see how they perform. And obviously the standard interview, and then we have a discussion group, which is non-clinical, just to see how they interact with other people and do they say anything weird. And ultimately, once I've kind of selected, I need to check my staff are good enough to go out, essentially, by themselves as part of teams. And certainly when we were the new service, we needed to check all these people we'd taken on could actually do the job we'd taken them onto, because we were kind of going flash to bang quite quickly. At the time, we had brand new SOPs, we had brand new kit. We needed to know that they could kind of do the business. And as I say, test all the non-clinical skills as well. And certainly, I think as I've progressed through different phases of training over the last 4 years, I've just rewritten again now how we're doing it. We've got a training week in November because we're going 24/7 in April. So I've got a whole load of new staff to train. And I've concentrated actually much more on the non-clinical skills than the clinical, because you kind of presume a consultant in anaesthetics knows how can cannulate, can get IV access, but it's all the non-clinical skills and the decision making. And there's no better way to test these skills than putting somebody in a kind of simulated environment. You just can't test. You can't test them with an exam. Obviously, so when I get my guys in, clearly putting them in lectures, probably how you lot feel now. It's a bit boring. I wish you'd shut up. So we don't do very much in the way of lectures, very little. We do a little bit for some of the CCPs, but it's all about simulation. Certainly the week we did, a couple of weeks we did back at the start, we had over 50 scenarios. We got the fire guys in to help us. Lots of mannequins initially, just to kind of get them into it. And then towards the end, we rank things up with some trauma actors, because they're great, because they scream and make a fuss, and it kind of puts much more stress. And still, I know the very last day we set up a kind of night simulation. We had a really busy day, and then we were staying in a pub down the road. We all had some dinner, and then I said, right guys, everyone feeling nice and comfy? Yeah, it's been really hard today. It's really wet. We're all, we're feeling a bit tired. I was like, brilliant. Back in the vans, off we go, and we took them back to the training area, and did 2 really, really horrific sims in the dark. And some of them were absolutely broken and shaking and crying by the end of it, but it was great. And they come to me now and they say, do you know, that was one of the worst things I've ever done. And that's the whole point. That's what the military do to me. The military absolutely broke me in my basic training, because I then kind of hit my low, and anything from then onwards, any dark day in Afghanistan, I was like, do you know what, it's not as bad as basic training. So I've kind of given them that reference point of kind of the worst possible day. So I'm hoping everything above that they should be able to cope with. And this is just a few pictures, so you can see we have to do these things in the environments they're going to be working in. This was a simulated explosion. This was, and they're working with other agencies. They're working with fire, with police, and just trying to figure out some of the logistics. And you can see that we can get quite realistic kind of actors with kind of strap-on bits of leg blown up. All very nice. Oh. Now I'm going to see if the technology works. It's just a quick video. Is it going to work? Do I need to click it on here, do you think? Yeah. Oh, we're going to see. If it doesn't work, it doesn't work. It's just a... Can you click on the thing? Do you know what? Should we mouse has died. Never mind. Resuscitate the mouse. We'll just move on. It's fine. So if I can get it working at the end, I'll show you. It's just a video of them all getting beasted, basically. It's quite nice. So how do we keep performance high? Daily drills, walkthrough, talk through, all the stuff I learnt from the army. But certainly, because we're obviously not just there for 3 months, we're here forever, hopefully. We have monthly clinical governance days, can be a bit of a bear pit. We're looking at kind of standard auditable material, making sure that what we do, because what we do from the outside probably looks quite risky. We're giving blood, we're putting people to sleep, we're doing it on the roadside, we're doing it in the house. We need to make sure we're not as good as the hospital, we're better than the hospital. And I'm sure one of my colleagues in the audience, Chris, the amount of scrutiny, if I put someone to sleep in hospital, as long as they don't die, no one really cares. If I put someone to sleep pre-hospitally, every single thing I do will be scrutinised. And that's a really good thing because that makes us work, at the highest possible standard. That's the same in all kind of high-risk things. So, pre-hospital anaesthesia, blood, transfers, children. We have key performance indicators. We've set these ourselves, and they're not something to beat us with. They're something to help us make sure we're working at the level we should be working. And we do lots of case discussions. We do lots of kind of peer review and lots of at the start, we had loads of external scrutiny, so we were always aiming to kind of be better than we already were. And as I say, we've kind of passed the baton back then. So a couple of years ago, I got asked by the military, could you go out to America and run a kind of tri-service, multinational hospital exercise? Just from scratch, just there you go, write it, go and do a visit, and they'll show you all the kit they've got. And they literally had, you put up a whole hospital tent, a whole thing, and we call it a 2-on-2-12, so 2 ED beds, 1 theatre table, 2 ITU, and then 12 ward beds. And what you're going to do is you're going to take 2 field hospitals of people out and just, we want you to come back and tell us that they're okay. So I suppose a bit of a validation exercise, but it's more of a training thing because we weren't going anywhere, so it's just training. So it's all integrated Serpent 16. Hasn't come out particularly well. So all down the side there is all my different beds, and so I put on I think it ended up being about 5-day exercise of different casualties coming from point of wound and having some care, going to ED, going to theatres, all the rest of it. And I had every department and every person in a certain job role had a certain training objective or learning objective that they needed to get ticked off, kind of to see that they could handle dead bodies properly, to see that they did the right thing with blood, to see that they followed SOPs. And I can't tell you how many people are in a field hospital, I should know really, but there's quite a lot and quite a lot of different roles. So as I say, we went from point of wounding through to ED, and this is the sort of thing we'd be going out to now. We're not going to be going out to a nice hard-built bastion hospital. We'll be going out in a tent somewhere vile. So this is why we've got to get the guys training like this through to ITU, into the wards. And we had to exercise everybody. We had to exercise, all the kind of people that help, but also the non-clinical stuff. So we call it high com, so the higher command. So a hospital runs in the military in a slightly different way. The chain of command's a bit different to Civvy Street. So we had to test them as well. So this is one of my colleagues dressed as a dignitary, coming to force his way on because there's a sick child from his village in there, and he wants to get in, and testing that the higher command do the right thing. So I suppose in conclusion, hopefully I've caught up a bit of time. What we're looking to do in the job we do is kind of train hard and fight easy. If our training is very, very rigorous and robust, then hopefully the day job should be a little bit easier. And high-performing teams, we can't avoid the stress. What we do is stressful, so it's kind of embracing that stress. And it is, again, it's a bit cheesy, but pressure does make diamonds. If you get used to embracing the stress and learning to cope with how to work in a stressful environment, because we can't make it less stressful, then hopefully you start to function at a high level. And I think it's a military thing, but if you can get people to rock bottom and then build them up again, it does give them a reference point, and it does develop coping and resilience. And I'm not going to talk about resilience, but I think it does have a big role in at least it's not as bad as what Amy did to us. And there is a degree, certainly, when you're seeing things that you maybe haven't seen before. So our EM nurses, you know, we do lots of desensitisation because maybe they haven't seen the sort of things that, you know, it's one thing to do an arrest in a cold clinical, you know, resus room. It's something else to do it in the patient's front room with all their family photos on the wall and their wife crying at you. So that's what we try to simulate when we're putting our guys through this training. And reduce mental load where possible. I say, you know, having SOPs, having things that you drill and you simulate, so everybody knows exactly, you know, the way we do an RSI is absolutely regimented compared to how we do it in hospital, which is whatever mood the consultant happens to be in, whatever drugs they choose to use. This is all regimented so everybody knows I'm not going to be using my cognitive load thinking about what induction we're going to do, because I know what we're going to do and I know what kit we're going to use because it's always the same. And then that kind of gives your brain a little bit more space to worry about all the other stuff. And I'll just leave a quote up there. I'm not going to read it, but essentially it is kind of, you know, trying to get people to work under pressure as effectively as they can. And I think for high-performing teams, that's the key, certainly for the sort of work that we're doing with the pre-hospital and with the military. You know, you're never going to have a good environment to work in, but it's kind of getting your brain back on track to kind of, they talk about kind of red and blue thinking. But you need to kind of embrace that and pull your emotions to one side and pull yourself so that you can actually perform effectively when you really, really need to. And hopefully I've caught us up a tiny bit. And I'm happy. Do you want me to do the question bit? Do you want to come up and...
Yes, first I want to say thank you.